We are going to get started. My name is Chris. Welcome to another Shankle Clinic webinar. It's my pleasure tonight to introduce Dr. Shankle, a man who truly needs no introduction. He is his own unique cabinet of curiosities, a statistician, a dedicated clinician, a lover of Siberian Huskies and Bermuda Hedrons, and moreover, a researcher extraordinaire with over 100 publications to his name. As one of the country's leading experts on Alzheimer's and other neurodegenerative diseases, Dr. Shankle has spent over 3 decades treating patients, conducting research to advance our knowledge, and developing new treatments and diagnostic criteria to delay or prevent the progression of cognitive impairment. Tonight, he'll go over some research on treatments he's pioneered in his clinic, as well as the research project he launched this year called the Epitomic Study. In the months ahead, we will be sure to share more updates on the Epitomic Study, the highs, the lows, the insights, and the future. If you have any questions that are not answered tonight, please call or email the Shankle Clinic, and we will do our best to address them. Dr. Shankle will speak for around 40 minutes, and then we'll do a 15-minute Q&A. If you have a question, please use the Zoom button below to ask it. I know you have many mystery novels still left to read, so thank you very much for sharing your evening with us, Dr. Shankle, and teaching us more about these diseases. Without further ado, I'll pass it over to Dr. Shankle.
Do you share the screen or
I
do
think you share the screen.
I don't have a share button.
Okay, hold on. I think you can. No? Do you not see it on there?
No. Maybe it's up here. No.
Sorry
That's
for
so
the technical
bizarre.
difficulties. One sec. Okay. How about,
Oh, I know. It
what if I
was
just made you the host?
the captions were blocking the share buttons.
Okay.
All right, here we go. Okay. Thank you all for coming tonight, and I'm very excited about what we're doing now. I think it's got the potential to treat not just Alzheimer's, but potentially virtually every degenerative brain disease. And it gets down to be relatively simple. So I will hope to be simple. So why do some current treatments change the course of Alzheimer's and other degenerative brain diseases? They do so because they treat the causes of the disease. And briefly, they are basically just cell stress, misfolding of proteins in the cell, which leads to neuron death. This is an example of a cell that has been damaged. The red circle with the dividing line is a damaged protein, and that can occur from a wide variety of common sources of cell stress: uncontrolled medical conditions, emotional, physical trauma, acute illnesses like a urinary tract infection, environmental toxic exposures, genetics, and lifestyle. They all are factors that can all damage proteins. And I've in fact seen this very frequently when we assess patients at the clinic and look at for cognitive changes. If we see cognitive decline, we look for the reason, and usually we can find the reason. And most of the time, it isn't progression of Alzheimer's. It's usually one of these things that further induces the misfolded proteins that further progresses Alzheimer's. So it's not just it is something that you can do something about. These are what misfolded proteins actually look like, and they occur in virtually every disease, every degenerative brain disease that's been studied. They have different names like tau, TDP-43, amyloid, alpha-synuclein, tangles. All of them are misfolded proteins. And the immune system, when the cell can't take care of itself, it triggers the immune system. The immune system identifies a misfolded protein, which is shown on the left-hand side. These purple guys are actually individual misfolded proteins that have aggregated onto a bigger one. And if they're not removed, what they do is they anchor to the membrane of the nerve cell, and that anchorage blocks the conduction of electricity so that the nerve cell can't generate an electrical signal. And if enough of that happens to the cell, it dies. That is believed to be the cause of all degenerative brain diseases. And so what your immune system does, it's signaled to come to the rescue to the cell, and it makes antibodies. That's the red guys here that attach to the purple guys, the misfolded proteins. And it's very specific. The immune system makes an antibody for different shapes of different misfolded proteins, not just a single one. The antibodies then transport the misfolded protein out of the brain. And as long as that keeps up with the production of the misfolded proteins, everything is hunky-dory. But if the misfolded proteins outstrip your immune system's capacity, that's when degenerative disease starts to begin. So if we want to treat degenerative brain disease, we have to remove its cause, misfolded proteins. And I started to test this hypothesis about 11 years ago, and I'm very convinced that this is a major reason for degenerative disease, and it has treatment. So why is there a general perception that treatment of Alzheimer's and other dementing disorders is ineffective? A number of reasons. First of all, we don't diagnose all the causes of Alzheimer's and related disorders. In fact, unfortunately, most doctors will stop at saying, oh, you have mild cognitive impairment or you have dementia. Okay. A few of them might go a little further and perhaps diagnose Alzheimer's. But as you will see, that's not sufficient. Since we don't diagnose all the causes, we cannot treat all the causes. So that's another big reason that we perceive the treatment to be ineffective. Furthermore, we rely on symptoms as our measure of efficacy. Well, that's fine, except for virtually every chronic disease, symptoms are the last third of the disease. 2/3 of the course of chronic diseases occur before symptoms appear. So we need to, we don't currently measure whether a treatment is actually reducing the amount of disease. That has to be done. Now, this is not new. Measuring a disease to prevent symptoms is commonly done in other conditions like high blood pressure, diabetes, heart disease, etc. We get a blood test or a blood pressure measure, and if it's high, we adjust the treatment. We don't wait for symptoms to develop, okay? Now, the field of brain function has not reached that point, unfortunately. But there's no reason that it cannot be measured before symptoms occur, and it cannot be treated to prevent the development of symptoms. I've seen that in a number of individuals. We now have about 20 patients who had all the biomarker criteria for Alzheimer's and no longer meet those criteria. And it also corresponded with an improvement in cognition, stabilization of function. So these are real things. My point about just diagnosing Alzheimer's is shown right here. This is a graph of two different misfolded proteins. On the x-axis, we have tangles divided by the tau ratio. On the y-axis, we have amyloid divided by tau. And when we have spinal fluid on, actually, this is 557. We now have more than 1,300. And when we look at the people who meet the diagnostic criteria for Alzheimer's, everyone below this red horizontal line meets that criteria, okay? However, if they have what's called a ratio on the x-axis that's less than, I think it's about 1.16 or greater than 0.20, that means they not only have Alzheimer's, but they have another condition. And that means that of these patients, only 10% had just Alzheimer's. So that's why I say that, just diagnosing Alzheimer's is only going to lead to treatment of part of most people's pathology. This is a picture of a study that I'll be telling you about later, the epitomic study. And the point of this is that if you look at a single individual and you have a way of measuring how many different misfolded proteins they have, you will find that most of them have 20 or more different misfolded proteins. And they also require 20 or more antibodies that recognize each of these sequences of letters, each of which represents a different misfolded protein with a different shape. So your immune system has to make an antibody that recognizes that shape. It's not going to recognize other shapes. It's very specific. So how can any current treatments be effective? Well, very simple. They either reduce the existing amount of pathology in the brain or they block production of new pathology. So I'll give you some examples. And these are examples where I've measured baseline levels of the misfolded proteins, put the patients on treatment, and then after 1 to 3 years, repeated that measure and seen that there was a reduction in the amount of disease, and it was related to the introduction of a specific treatment that I'll show you. Dipyridamole, what does it do? It actually has been used for stroke prevention, but not only that, it blocks hemorrhages and blood-brain barrier disruption by inhibiting the release of amyloid in blood vessels. It also increases blood flow to the brain, which actually improves cognition. Memantine is a very commonly used treatment for Alzheimer's. Just excuse me for 1 second, there's some sort of noise. Sorry about that, I don't like competing. Memantine blocks tangle production. It also improves learning, memory, and language very reliably. I've treated probably 5,000 patients this way, and it very reliably improves memory and language for 2 to 3 years. It blocks damage from stroke, anesthesia, head injury, and so it's not just specifically for Alzheimer's. It has a very protective effect against many different types of pathology. That's why when patients have a surgical procedure, I strongly recommend that they not stop memantine because it does protect their brains from the damaging effects of general anesthesia. Ribostigmine and galantamine do a slightly different effect. They block the production of amyloid, and they also improve working memory and visual abilities like recognizing objects and finding your way to familiar locations. When you combine memantine and ribostigmine or galantamine, Ali Atri showed back in 2008 that that combination will delay the progression of Alzheimer's by 2/3. Okay, that alone. And I was using that for years until about 2011, when I became much more aware of the underlying causes and started investigating for other things that directly addressed the underlying causes. Now, these are supplements, and some people poo-poo supplements, but there's a lot of scientific evidence on these that these actually work. Probably the one with the most dramatic effect that I've seen is something called Percepta. It's derived from a plant called the cat's claw, and it's found in the Amazon jungle. How appropriate. I can actually calculate how much amyloid it's going to remove from a person based on their weight. So it's extremely reliable. And most patients, I've treated about 500, most patients will show memory improvement objectively within 12 months. Lithium orotate was recently had an article in Science or Nature that showed that it actually blocks and maybe removes tangles. There have been human studies that show that certain dose ranges of lithium orotate are effective and safe. And so we've started using lithium orotate. And I was recently surprised that I was perhaps going too low. Some of the data show that you could go up to about 150 milligrams instead of the 50 that I was using. DHA is a form of fish oil. The Norwegian studies have shown that it blocks production of tangles and tau by 30% at the right dosage, which is typically about 4 grams a day. Green tea extract. Green tea blocks a different misfolded protein called alpha-synuclein. It also blocks amyloid. Alpha-synuclein is the misfolded protein found in Parkinson's and Lewy body disease and some other rarer conditions. And it turns out that countries that consume green tea, in fact, have a lower incidence of Parkinson's disease. Cerefolin is a natural supplement, and it turns out that in persons who have a high level of something called homocysteine, it prevents the development of B12 and folic acid. The consequences of this are that if you have high homocysteine levels, it causes blood vessels to kink. And when they kink, they reduce your blood flow, and it's a definite risk factor for heart disease and stroke and dementia. By giving cerefolin and bringing the homocysteine level down to normal, you see increased blood flow, reduced brain atrophy, reduced vascular disease, and improved cognition. We've published several studies on this. Now turning to non-medication treatment, that's quite impressive. This is the Coaching for Cognition trial in Alzheimer's disease that we conducted called the COCO study. It was actually based on a much larger international study called the Finger study. Now the United States has one called the Thumb study. And what this showed was that a certain regimen of diet, mental exercise, physical exercise, and management of medical conditions had a dramatic effect on the course of Alzheimer's disease. So we basically took these guidelines and applied them to a study population from the Shankle Clinic, where everybody got the guidelines, but one group got a coach that they had to report to and to help ensure compliance, and the other group just had to do it on their own. Well, the cognitive exercise was something called Brain HQ, which has an extensive amount of research. It was developed by a Nobel Prize winner in the plasticity of brain connections. And he and his colleagues developed a very impressive series of cognitive exercises. They are geared to your level, and then they help build you up to higher levels. What they have shown is that Brain HQ itself can reduce the risk of dementia by 29% in older, healthy adults over a 10-year period. And after 40 hours of the memory exercises, there's a 10-year improvement in memory. So this isn't just for impaired individuals. This is for all of us. When we actually did the final analysis, we showed very clearly that the group that just got the guidelines, but not the insurance of compliance, they definitely did not do as well as the group that complied with lifestyle with a coach. I'm not saying you have to have a coach, but what you do have to have is compliance. And so some people need a coach, some people don't. Some people need it just a few times a year. Some people need it more than that. But whatever it requires to comply actually works. When we actually did the calculations, what we found was compared to not only the control group in the clinic, but also to the national standard of care. That's shown in the yellow bar. And what we found is that after 1 year, when everybody was the same at baseline, and after 1 year, uh, people who were given the national standard of care had already developed mild cognitive impairment. By year 3, they had developed mild dementia. By year 6, they had developed moderate dementia. And by year 8, moderately severe dementia. If we looked at the treatment group in the clinic, they actually showed no decline over a 2-year period. And if it was extended out, the projected rate of decline was that they would still not even be in the mild cognitive impairment stage. Other members of the clinic who did not get the coach and didn't necessarily comply as well, they showed a rate of decline that was slower than the national standard of care. That was very encouraging. But they didn't do as well as people who definitely complied. So there's a real difference between, the treatment that we give is better than the national standard of care, but adding in lifestyle is a big effect. And that effect translates into dollars. In terms of healthcare costs, it saves individuals about $100,000 over this 10-year period compared to the national standard of care. Well, what about the newly approved treatments for Alzheimer's? You're getting bombarded in the advertising world by these antibody treatments. Some of them are called donanemab, others are called lecanemab, and also known as Leqembi and Kinsula. As some of you may know, I'm not opposed to using these treatments, but I am opposed to using them when they have a significant risk of harm. And the reason I'm concerned is that when they did the FDA clinical trials, they required that people have less than 4 microhemorrhages in their brain to be in the study. I'm not sure I have a single patient out of 500 who has less than 4 microhemorrhages. So what I say is they stack the deck. Even so, with that very rigid criteria to eliminate any chance of hemorrhage, 25% of the people who received Kinsula had microhemorrhages. 15% of them were larger hemorrhages that extended across whole segments of blood vessels. Leqembi or lecanemab did better, but still we're looking at a 20% risk of brain hemorrhage. And you'll up and hear, oh, well, they weren't that significant. Well, I'm not sure, because if you include the general population, most of them have more than 4 microhemorrhages. Many of them have an E4 gene, which greatly increases the risk of hemorrhage. So these numbers that you see here are probably a minimum estimate. And this is the reason for my concern. Any benefit could be overshadowed by a significant hemorrhage. So furthermore, these treatments remove amyloid. They don't remove tangles, okay? Once the tangles have spread to the second area affected by Alzheimer's, which is the hippocampus, people can no longer compensate on their own to keep track of appointments, recent events, things to follow up on, like using a calendar to compensate for any memory loss. Once we're over 45, everybody's memory gets worse, but we all find ways of compensating it. Calendar, an iPhone, whatever you use. And that works. And as long as that works, everybody's functioning normally. But if that method of compensation fails, then a spouse or somebody has to help out and keep track of the person's schedule. That's what mild cognitive impairment is. It is a clinical stage. The stage where you can compensate on your own is part of a normal aging stage. So once they have the plaque, the tangles have progressed to the hippocampus, the second place, that's when mild cognitive impairment begins. By then, it is too late for these treatments to be given both safely and effective, because as the disease increases, the risk for brain hemorrhages increases, even if you don't take these medications. And again, by the time you have mild cognitive impairment, you've got plenty of tangles that are going to continue to spread in spite of whether you take Leqembi or Kinsella. Furthermore, there's the cost of IV infusion services, intravenous deliveries. It's not cheap, and it's risky. So if I'm using Kinsella or Leqembi, my criteria are it has to start while persons are in the normal functional stage. There's lots of people with diagnosable Alzheimer's or other dementias in this normal functional stage before mild cognitive impairment. They can compensate on their own for their own memory difficulties. And that's the first criteria. The second criteria is they need to have very few microhemorrhages in the brain. And as far as I can tell, that is not common. So the reason I say before mild cognitive impairment occurs is that is when there's the greatest chance that they have almost just amyloid. Amyloid is the first misfolded protein to occur in Alzheimer's. So there's a greater likelihood that a person will have just amyloid when they're in that normal functioning stage before mild cognitive impairment. So those are my rules. Now, I think I've made a point here that Alzheimer's is not a homogeneous pathology. It's not a single misfolded protein. It's highly variable, highly heterogeneous. And that suggests that a single antibody is not going to be fully effective. And one needs more than one antibody to recognize all the different shapes of misfolded proteins and remove them from the brain. This is actually one of the primary goals of the epitomic study, which I'll tell you about, to really define the specific misfolded protein pathology in everybody's brain so that we have a patient-specific fingerprint of the disease, regardless of whether you have symptoms or not. This is an example. Here you see, again, I think I showed this earlier. This patient, single Alzheimer patient, had 22 different antibodies to remove 22 different misfolded proteins. And if you look at Kinsella, it may serve like this antibody or this antibody, but it's certainly not going to remove this whole array of differently shaped misfolded proteins. The same goes for Leqembi. That is why I don't think it's a completely effective treatment. Now, I've used intranasal polyclonal IgG antibodies for about 11 years. And before that, I used intravenous and polyclonal antibodies. What that means is that these are antibodies you can prescribe from various vendors. They are derived from blood donors, thousands and thousands of blood donors that pool their blood together, and they extract out the antibodies and they purify them, clean them, and they sell them. In intravenous delivery of these antibodies, and by the way, because they're coming from many different sources, there are many different types of antibodies that would bind to misfolded proteins. So when I was giving it intravenously, it was very clear that it was working. In Alzheimer's patients, it delayed their progression by 200 to 700%. It stopped progression for 2 years in Lewy body patients. And I even had a multi-system atrophy patient with a life expectancy of 2 years who was stable for 5 years. So it is quite impressive, but the price tag was $10,000 a month, which obviously precludes its widespread use. So back around 2015, I think, I learned a study in which the mouse was given these IgG antibodies and have them inhaled through the nose, and it compared how well it got into the brain to how much went into the brain when they give it intravenously through the blood. And what they found was when they give it through the blood, only 1/10 of 1% of all the IgG antibodies get into the brain, 99.9% don't get in. I never understood why we treat, to this day, neurological diseases of the brain with intravenous therapy when we know that 99.9% of those antibodies aren't going to get in. Well, when they compared it to the intranasal delivery, it turns out that the antibodies, the IgG antibodies given intranasally, got up into the brain up to 1,700 times better in very important areas, like close to the brainstem where Lewy body and Parkinson's disease, and close to the hippocampus where Alzheimer's disease begins. And over the last 11 years, I've treated Alzheimer's, Parkinson's, Lewy body disease, traumatic brain injury, even one Dallas Cowboy with chronic traumatic encephalopathy, and a patient with lupus. And all of these groups of diseases responded in very clear, objective, and subjective ways. In fact, the patient with chronic traumatic encephalopathy, one day I got a call from the wife and she goes, "You got my husband back." I mean, I've heard that so many times now. It's anecdotal, it's subjective, but there's plenty of objective data to also support that. So what this convinced me is that if we, in fact, try to remove as many of the misfolded proteins as possible, that you do see a better outcome. And that supports this hypothesis that the misfolded proteins are a major cause of all degenerative brain diseases. So I often tell people that what we're really doing is a numbers game. Treating the cause of a neurodegenerative disease is a numbers game. And as using intranasal IgG as an example, I measure the amount of misfolded proteins at baseline, then I initiate a treatment. We monitor their cognition and function about every 4 months. And then after a year and a half to 2 to 3 years, we repeat the expensive tests, the spinal fluid measures, the MRI measures, and we can quantify all those data. And what we find is that if the levels of the misfolded proteins have not changed, the patient has not changed. They've stayed the same. They have not gotten worse, okay? If we see a reduction, which we often do, then there's partial improvement. It's only when the patient is not treated that they are guaranteed to show an increase in these misfolded proteins and guaranteed to decline. Now, let's say I've repeated the measure and there was some increase. Well, what do? I adjust the treatment. Just like if you had a hemoglobin A1C of 7%, your diabetes doctor would adjust your diabetes treatment. There's nothing different about it. It's very commonsensical. So what is the next frontier? I believe it's going to come from the epitomic study. And I hope all of you will participate. There's no cost. It can help you. It can help your family members. There's no reason not to. The epitomic study, what it does is it takes one tube of blood and we send it over to Dr. Glabe's lab at UC Irvine, and he has developed a special array of 1,000 wells. Each well has a different misfolded protein, and that tube of blood has your antibodies. So he pours the blood over the array, and some of the antibodies in your blood will recognize some of the misfolded proteins, and they will stick, they will bind. And the colors are just an example of what that might look like. What it is, literally, is a fingerprint of the disease. It's specific to each patient. It's not Alzheimer's, it's not Lewy body, it's not Parkinson's disease. It could be a wide mixture of these things. It doesn't matter. It's patient specific. And well, what does that give us? Maybe I'd be scared to do this because I don't want to know. Well, here's why you want to know. First, we need to know the fingerprint of the individual. Once we have that fingerprint, then we are submitting to the FDA a phase trial, clinical trial, where we will take that fingerprint of each patient and extract the most effective antibodies they have and have them inhaled intranasally. Now, just so you know, the current treatment idea with the commercially available human polyclonal IgG like GammaGuard or Privigen or Gamunex, et cetera, only 5% of those antibodies actually target stuff in the brain. In this one, it's 100%. It's also patient specific. So just simple math would indicate that removing the person's fingerprint, their best antibodies, and giving them intranasally will remove somewhere between 20 and 100 times more disease than what I'm currently able to do. And what I'm currently able to do has been better than anything I've ever seen in 38 years of treating patients. So I'm very excited about this. The commitment is almost nothing. We need 1 tube of blood. We also need it from the spouse and family members if possible, because with the family members who don't have symptoms, they often have a subset of the patient's antibodies that are 20 times more effective at removing disease. So if we can identify those most effective antibodies in the family members, we have the potential for using those to treat the patient, as well as the potential for prevention in the family members. This is not pie in the sky. So that's why I'm so excited. Our goal is to have all 500 patients in the clinic participate and as many family members and spouses as we can. It's free. There's no cost. And like I said, it's 1 tube of blood. For the family members, we also give the memory test that their mother or father has taken many times at the clinic. And that's it. There's nothing else. We work with Dr. Glabe then to get the results. And over the next year, we will be identifying what are the most effective antibodies in each person. And hopefully the FDA will approve the study. Usually takes 12 months to get FDA approval. So that's our timeline. So please consider this. It's very important, and it has the potential to treat any degenerative brain disease, not just Alzheimer's disease. So I want to thank the 501c3 nonprofit Foundation of Memory, because they have really provided the support to make this free to everybody.
All right, thank you so much, Dr. Shankle. I think we have a couple questions that have come in. So if you are happy to oblige, I will ask away. So I think the first question, has Charlie Glabe, recognized all of the misfolded proteins, that are out there with the
Oh,
epitomic study or with his epitomic, platform?
that's a great question. I don't know the answer, but I can tell you something that's probably relevant. It turns out that when proteins misfold, they can misfold into certain groups or aggregations of shapes. And for example, amyloid is not a molecule. It's not a misfolded protein. It's a superstructure. And just like the Empire State Building. And there are 8 different classes of superstructures of amyloid. And the different underlying misfolded protein might not be amyloid. It might be tau. It might be alpha-synuclein. It might be some other misfolded protein. But when it aggregates, it tends to aggregate into these superstructures called amyloid, of which there are 8 different groups. And then when they form that superstructure, they combine with other superstructures to create bizarre complex aggregates. So Dr. Glabe has identified 1,000 different binding sites that correspond to these misfolded proteins aggregates. Whether that comprises every binding site known, I don't think so, but I'm pretty sure it comprises the majority.
Okay, thank you, Dr. Shankle. Can you talk a little bit more about, the 12-month timeline with the FDA? What are your plans on doing a clinical trial, all that sort of thing?
Well, we have identified what the roadblocks are, and so uh, we've identified a group that will be able to extract the antibodies that are effective for each patient. The next step is to identify a facility that is certified by the government to clean the antibodies to meet FDA standards. That's We're in the process of doing that. Once that is done, the majority of the rest involves writing the application, submitting it, responding to the FDA. They typically come back many times with questions, and then that whole process takes about 12 months on the average.
Okay, thank you. Someone else asked, if folks can be tested for microhemorrhage and how do you generally find, microhemorrhages?
So microhemorrhages are things that you see on an MRI. You can count them. And in fact, I'm a data Nazi, I guess. I count the number of microhemorrhages in each person's brain, and then I compare it to the automated program that counts them. And we usually agree pretty closely. On an MRI, there's a special sequence done with an MRI that shows up hemorrhages as black. And they are typically connected to a blood vessel, but they are a dilation of the blood vessel. So you can tell they've kind of hemorrhaged.
Hmm. Thank you. What someone's curious what you think of the curve therapy or maybe the curve technology. Do you want to talk a little bit about the
Sure,
intranasal inhaler?
sure. When I learned about the mouse study and found out that, it was getting antibodies into the brain, literally hundreds of times better than the blood, I searched for the best inhaler that could do it. And the characteristics of that inhaler are it has to be able to reduce the droplet size below a certain amount to get into the brain. It also has to spray the antibodies into the nose so that it completely covers the nasal membrane, the nasal mucosa. And the best inhaler I could find was the curve inhaler, which has been used in a number of clinical trials, FDA clinical trials. I think that's the positive side. The negative side is that, it can clog. Antibodies are thick. They're not like orange juice. They're more like honey. And so uh, you have to have a way of cleaning them to be able to get them to continue to be useful. Uh, However, every time I've seen that an inhaler got plugged or a part didn't work, the company was very responsive. They provided either a new inhaler or an upgraded inhaler or a fix. And so the majority of people have been able to continue to use the inhaler even when a problem occurred.
Thank you, Dr. Shankle. So someone else had a question about, whether participating in the study will benefit their spouse with a, cognitive issue, or if it would just benefit their children. I think that sort of, the larger question still is
Yeah,
around like, when would a clinical trial take place, right?
sure.
Um, yeah.
Well, so the first question is the hypothesis that misfolded proteins cause degenerative brain disease correct? And by actually giving treatments that lower the misfolded proteins, I've seen that that hypothesis is true. So then you ask the question, well, if I then remove 20 to 100 times more misfolded protein with the epitomic study, it should result in much better outcomes. It's also very safe. I haven't had a single serious complication in 11 years in over 300 patients. Um, let's see, I, I lost I lost the track of that thought. But
Yeah, I think that, I still think the overall question is just, is it feasible to start a clinical trial soon? I mean, is the FDA gonna,
I've
make
never,
you,
yeah.
yeah, sorry.
I mean, this is the first time I've applied to the FDA to actually do my own clinical trial. So this is a new experience. We did get input from someone with 40 years of experience in getting FDA trials approved. And unfortunately, this individual is in hospice and so can no longer help. If anybody would like to help who's got experience, we'd be happy to have them. But um, I got the impression from this expert that we shouldn't encounter too many difficulties getting approval. I sure hope that's true.
Okay, let me see, maybe a couple more questions.
I just, well, if I wasn't clear, yes, it should help the patient. It should help prevention in the family.
Okay. Um, Someone's asking a question about, whether it's important to back up the nose pieces, since that appears to be one of the weak points in the curve inhaler. Do you have any thoughts on that?
I'm certainly not an expert on the parts that break. I leave that up to the representative in the company. His name is Mark Giroux, and he's usually been very responsive about that. But I do know that so a jewelry cleaning machine makes it much easier to not have a problem. And the inhaler tends to work very well with that kind of a jewelry cleaner.
Okay. Um, yeah, I mean, yeah, I mean, okay, let me see how to ask this question. Is there a way to to give the treatment, pre-FDA approval? If like if what you're doing is functionally pretty similar to Privigen, it's just, what do you have to do there?
Um, I've been given different answers from different people. I think I'll be meeting with someone who can answer that question tomorrow. So I can't answer it right now, but I'm hopeful that I'll be able to tomorrow.
Okay, great. Okay, let me see if there's any other questions. Do I guess, one other question is, do patients currently have like a misfolded protein baseline, based on their CSF biomarkers, their blood biomarkers, whatever biomarkers they have? And, how is the epitomic study and the misfolded protein profile that you're going to get from that going to change your sort of like, your view into people's diseases?
Good question. So I tried to get baseline levels of these misfolded proteins on every patient in the clinic. That involves a combination of spinal fluid, blood, and a skin test that we do in our office. That covers a large array of all the potential misfolded proteins. Yes, we do try to get that baseline, and then we then start treatment, and then we try to repeat that baseline several years later to actually see if we've been able to remove and reduce the levels of these misfolded proteins. I'd say at least half the time, and perhaps more. We still have to do the data analysis, but I see this regularly, a reduction in at one or more of the misfolded proteins, and it does correlate with the patient's course.
Great. Thanks. Okay, so I think maybe we'll answer, one more question. It looks like someone's mentioning that Brain HQ works really well, especially if they do around 2 hours a day. Does that seem sort of like the right dose in your mind? Tell us a little more about like how you think of Brain HQ as like a treatment with a dose.
Yeah, interesting. I met with the scientists at Brain HQ, and they did a study and they showed that longer duration sessions tend to be more effective. I had always recommended 15 minutes because I just wanted people to do it. But if they don't mind and can do it longer, there is a greater benefit for a longer duration. 2 hours is a lot, though. I mean, I never.
Yeah, more power to you. Yeah. Yeah,
I'm impressed. I'm really
yeah,
impressed.
for sure. Okay. All right. Well, thank you so much, Dr. Shankle. We really appreciated your talk. And to everyone listening, we'll let you know as soon as we have more information about the epitomic trial, when that might be, and then what kind of data we have coming in before that. But we'll keep everyone in the loop. So,
Keep your fingers crossed.
yep, for sure. Thank you so
Yeah.
much. All
Okay.
right. Take care,
Bye-bye.
everyone. Have a great night.
All right.